Thank you, Jose, and again, thank you for the honor of being here with you all in Miami. It's a wonderful meeting so far, and always enjoy learning so much from everyone. So we're going to talk about inflow and how to potentially correct this. Here are my disclosures. So why is this important? And I think it's really very simple. I think, we as glorified plumbers really need to try to simplify this whole idea of pathology within the venous system. And it's how I explain things to my patients. It's really sort of all about the pipe, right? Inflow, outflow. We're going to get the best results, long-term results, as long as those things can be accomplished. So since we've been talking about iliac stenting, I've really kind of focused on the purpose of this for that stenting procedure and for outcomes. So if iliac stenting is going to be planned, you really want the best inflow to aid in the long-term patency of the stent. As I mentioned, good inflow, good outflow. And stent occlusions typically will occur for three main reasons. One, the lesion hasn't been completely covered. Two is there is residual thrombus in that post-thrombotic iliac, and as you saw by the data, post-thrombotic stents occlude more commonly than just the nivels. And then you also have the poor inflow. So let's address this poor inflow. When we talk about infrainguinal disease, especially the femoral and popliteal, above the knee popliteal, this affects that flow. Again, remember the pipe, it affects the flow from that knee area up to that groin. And then if it's affecting the common femoral level at the groin, it's going to affect that iliac flow. And poor inflow to the stent can increase the risk of that stent occlusion. So the real recommendation here is you want to maximize all common femoral inflow channels to get that best overall flow and pressure into that level and then ultimately into the iliac. There has always been this argument that if there is femoral vein disease, that all you need is a profunda flow to maintain that iliac patency. But I'm going to argue that not all axialization of the profunda is the same, or is it adequate? And what if the profunda itself is diseased? Because I don't think we really look at the profunda the same way as we do femoral veins when we do our imaging. And we certainly don't use IVC in the profunda to identify poorly visualized lesions as we do with venography. So the key here again is good inflow, which is going to lead to good and persistent outflow. So here's the anatomic consideration. Let's say you have a femoral vein occlusion. You're going to get axialization of the profunda, and you're going to have flow from the popliteal to the profunda, and theoretically decompress the leg, have good flow into the iliac lesion. Well, what if that profunda is diseased, which sometimes is really hard to identify, especially if it's not so significant in itself? And then what about the diseased tibial veins, or more importantly, the popliteal vein? If the popliteal vein is poor or insufficient, is hindered by any resistive pathology, the axialization therefore will be not as good and could theoretically be pretty poor to the profunda and suboptimal into the iliac region. So here you have the axialization that's occurred. You've got now popliteal disease taking away that good axialization flow, and it's going to lead to pretty severe calf post-thrombotic sequelae. So if the flow from the profunda and femoral vein is suboptimal, again, the flow into the common femoral iliac segments may be hampered and can lead to greater risks of stent failure. This is an example of a woman who was actually quite athletic. She had trauma. She had an underlying May-Thurner she never knew, but she ended up developing rather extensive iliofemoral disease as well as infrainguinal DVT. They treated elsewhere, I think she was in Utah actually, they treated her May-Thurner and got rid of all her iliac disease, but nothing was done for the infrainguinal segments, and she actually continued with rather severe venous claudication. She really couldn't do the activities that she used to do before her trauma, and even though her Villalta score was only 7, her venous claudication was very, very severe. And so we underwent the Access PTS protocol. We opened up her popliteal and femoral veins, got good flow restored, and out to 5 years, she did extremely well and was back to being very active. But here you can see the difference between the axialization that really doesn't occur in somebody with popliteal disease, and then once you get that popliteal open including the femoral vein, how that patency can remain. And her patency, actually, as I said, out 5 years was good. So here's my approach. First, we start with the venous Doppler. You want to define the anatomic distribution of the disease. You want to see if the common femoral and popliteal status, so that you understand how to position them. Most of these patients I'll position prone, start at the ankle, and then get into the popliteal once we cleared out the popliteal and treat the suprainguinal disease if there is any there. You really want to find out if this disease is occlusive or just if there's partially recanalized. This really kind of determines whether I'm going to do this in the hospital or my OBL. And then how I'm going to do it depends on, again, whether there's extensive occlusive DVT or chronic disease, or whether this is subocclusive and you have channels that you can work with. Because if it's occlusive and I'm going to use a lot of devices and it can be very expensive, I'll take it to the hospital and use access protocol. If I'm in the OBL, then I can get through those channels and use a lot of balloon techniques to really kind of recanalize these segments. And then if you're concerned about central disease, you have to really look at this and get the idea of what the anatomy you're going to be dealing with before you start, so you know how your approach is going to be in treating that central venous disease. Remember, the goal here is obtaining direct inline flow from the ankle to the right atrium. I really think this is the key for all the good results that we've had. Anticoagulation should be therapeutic and not discontinued. Again, as you heard earlier, access below the lowest level of the disease so you can clear out the entire pipe. You don't want to leave some of that disease below where you're accessing, because it's going to affect the inflow to what you've just treated. CTO techniques are typical to get across these things. Initially, venoplasty is used to create the working space, and then work from there to try to optimize your flow, whether it's in the hospital or in the OBL. And I do all this infrainguinal work before I'll even consider a stent placement, so that I optimize that flow into that stent and hopefully increase the chance of its patency. Once the flow is reestablished, and you get that flow from the tibials through popliteal and femoral vein, then I'll proceed with the iliofemoral stenting. I do not stent the fem-pop segments. Please don't do this. I've seen plenty of patients come from around the U.S. who get referred, who have me trying to get through these stents. I've yet to see one stay open for any period of time, and once they shut down, they are a bear to get across. Probably the most difficult venous occlusions that I've seen. And remember, I have this rule of ABCs that I tell all my patients: activity, blood thinner, compression. It's very simple, but it's incredibly important. You want them to use that calf pump to continue to pump that blood in their recovery period. So walking vigorously every day. They need to be therapeutically anticoagulated and use compression socks. I typically will DC them on enoxaparin, 1 milligram per kilogram, twice daily for 30 days before transitioning them to an oral anticoagulant. So with that, thank you.